Good morning, good morning, good morning. How's everybody doing today? Fantastic. I know. Hold your applause. Hold your applause. Oh, you crazy kids, you. I know. So how's everybody doing? Talk to me. Tell me something good. Okay, fantastic. Well, welcome to the final week of the semester. Good morning, Ashley. Good morning, Kyle. Good to see you, buddy. Needy, Alex, KB, everybody else who's already chimed in saying hello, Renee. It's good to see everybody. Welcome to class, final Monday. Are y'all excited? How are your summer school classes going? Are you ready to be done with them? Seems like we'll be done with them for 2 weeks, and then we'll be right back on it again in another month, you know? At least I don't know about for you, but for me, that's the way it feels. Just the semesters kind of run into one another. All right, so this week we are talking about psychological disorders. The next couple of days we're going to be talking about psych disorders. And then the final 2 days, we're going to be talking about the treatment of psychological disorders. For this week's Friday webinar, I'm going to have you ask you to take some personality disorder tests that are not valid, so don't get any ideas if you score one way or the other. But we're going to take a test this week, and we're going to talk about the process of diagnosing and treating psychological disorders. And hopefully you'll know the difference between a delusional disorder, schizophrenia, and the difference between a differential diagnosis and incidence rates. So hopefully we're going to learn a lot of cool stuff this week, sort of as a nice cap for the semester. All right, so let's go ahead and switch to the lecture if we could. Before we get started, goodness me. This is actually week 8 Kahoot Winners. I have a typo there in the top, but congratulations to Zara, Abir, and Donnie. Congratulations to all of you folks for taking home the championship this week. Thanks to everybody who played Kahoot this summer. I hope you had fun. It was kind of neat for me to see the winners each week, and I hope it helped prepare you for the midterm and the final exams. All right. So it's now 11:01. I guess anybody who is interested in the lecture is now here. It looks like we've got 8 viewers, which is a pretty good audience for a Monday. Let's go ahead and get started. All right, chapter 14. And howdy again. Chapter 14, psychological disorders. Today we're going to be talking a little bit about the difficulty of diagnosing disorders. I'm going to introduce to you the Diagnostic and Statistic Manual, 5th edition, and we're going to talk about what it means to say that you have a psychological disorder, and we're going to talk a little bit about the process of psych disorders. Now tomorrow we're actually going to talk about some disorders. We're going to talk about mood disorders, psychosis, thought disorders, and then a little bit about personality disorders. But today it's going to be more about the process of how we diagnose psychological disorders. All right, so you know what my friend the clinical psychologist tells me. Oh, and by the way, before I get started, let me go ahead and give you one caveat. I am not a clinical psychologist. I am not allowed to diagnose disorders. I do not have a professional knowledge of psychological disorders. If you hear anything this week that disagrees with what your clinical psychologist tells you, please, please, please believe your clinical psychologist and not me. Clinical psychology is an area of specialization that involves not only a PhD, but then an entire year. I think it's like 2,000 hours of supervised training. So there's a lot that goes in between me, a fairly clever PhD who has some friends who are clinical psychologists, and the actual practice of treating psychological disorders. So please don't get hung up with whatever I say this week. Is that good enough of a mea culpa? Buyer beware, right? So, from what my friend the clinical psychologist tells me, diagnosing psychological disorders is really hard because it's kind of complex. Different disorders can be caused by the same thing, or the same thing can cause different psychological disorders. There's variations and gradations between the characteristics of psychological disorders. It's not nearly as cut and dried as a textbook definition will lead you to believe. It's very, very difficult. And you know what causes them? You know, it's the same thing that relates to stress. If you remember, we talked about the biopsychosocial model. You know what? That's the same thing that we're going to talk about with regard to diagnosing psychological disorders. Why do people have them? Well, you know what? We do know that there are genetic components, and brain trauma do affect people's likelihood of developing psychological illness. You know, we do know from little Albert that the environment can train psychological disorders into us. Remember when we talked about attachment theory, and I suggested to you that it's a critical need that we all have. If it's not met in the first year, you will develop attachment disorders. You know what? Language disorders. If you remember, we talked about, oh my goodness, the wild child. Oh my goodness, I forget her name. The wild child. We talked about the girl who didn't learn to develop Jeannie, the wild child. She didn't develop linguistic ability because she was not presented with language during the first 5 years. And then if you remember, we also talked about ACEs, and we suggested to you that early childhood trauma can affect your psychological functioning. And then, you know what, socioculture, income level, gender, race. This is probably actually where I should put ACEs in the sociocultural matrix. So what causes psychological disorders? Man, it's very, very complex. Probably the best way to think about it, though, is presented here by the diathesis stress model of the onset of mental illness. The strange thing is about mental illness is a lot of them have genetic disorders. So just like we do twin studies and other behavioral genetic studies to see what your IQ, if your IQ is genetically predicted, just like we do that to see if your personality is genetically predicted, we also do that for psychological disorders to see to what degree they are genetically predicted. And you know what? They are genetically predicted. But at the same time, people with the same genetic material may not develop the same psychological disorders, or one of them may not develop a psychological disorder at all. And you know what? A lot of psychological disorders have onset times that are later in life. You know, most of them are going to be in your teenage years or later. If you have a genetic predisposition, why does it take so long for the onset to begin, right? If you have diabetes, you know, you have juvenile diabetes, you have it pretty early. It's not as if it takes a long time for this genetic problem to set in, but that does with psychological disorders. So probably the best way, one good way to think about it is this idea of the diathesis stress model. And what that suggests is that we all have you might have some sort of genetic or biological predisposition that makes you at risk for the psychological disorder. But it's not just that. There's also childhood trauma. Remember ACEs, and this can cause your brain not to develop properly. So the diathesis is we have some sort of structural informity, some sort of problem that is caused by either our genes or early childhood trauma that damages the brain. But then what happens is you may actually grow up in a world that has protective factors, or you may find a great husband or wife or marriage partner or relationship partner. You may find a great set of friends. You may join the military and find a great cadre of people that provide sort of a stress protecting environment. You may develop really good stress habits. And so the idea is that you may have a higher probability, but if you can escape the stress or particular stressors, you may not have the psychological disorder. So the diathesis stress model says, really, you know, we all come out with a certain genetic predisposition, but some of us may be put in a stressful environment that causes this disorder to sprout, and some of us may not. I hope that makes sense, right? Now, diagnosing disorders. Psychology really doesn't know what causes psychological disorders. Don't tell my clinical psych friend, and don't tell your clinical psychologist I said this, but we really are in the early stages of truly understanding where psychological illness comes from and how to treat it. If you're interested, I would say you should go to the resources folder, and and there are some videos there of some early psychiatric treatments, and you will be surprised at how barbaric and silly and stupid some of these treatments are that are less than 100 years old. You would be surprised what we've been doing up until recently to treat psychological disorders. And it's because we really, until the last 100 years, didn't have a grasp on what they were or how to study them. Now, in Freud's time, Freud is actually probably he's the first of a lot of things, but he's probably one of the first big clinical psychologists. And Freud used the case study methodology. So he would study individuals, and he would focus on what was wrong with that one individual as a unique case. Emil Kraepelin, and this is sort of an older way to think about psychological illness. The newer model, the more what we would call the modern approach, was ushered in by this fellow, Emil Kraepelin. And he was the first person to suggest that, you know what, maybe we should focus on symptoms rather than case studies, right? So Freud used the case study method, which was better than what came before Freud, but Freud still didn't think about individual symptoms and how one symptom could exist maybe in multiple disorders, or how one disorder might have multiple symptoms. So Emil Kraepelin was actually the first person to think about these symptoms, collecting symptoms as a way of classifying psychological disorders. He sort of, in his first major classical system, sort of revolved around disorders related to too much anxiety and disorders related to disordered thought. And you know what? That's still a pretty good classification. That's a good way to organize psychological disorders. And you know what? He was the first to identify these symptoms of schizophrenia, which he called dementia praecox, which is early dementia. All right? So he sort of ushered in this idea of looking at symptoms. Now, this was at the turn of the century, but psychology still didn't have really a scientific methodology until after World War II. And it was all of the mental illness and psychological problems that resulted in the country and with soldiers as a result of the trauma of war that really made it necessary for psychology, and especially clinical psychology, to get very professional and to make sure that everybody was trained properly in how to diagnose and treat psychological disorders. Probably before 1942, any of you could have hung up a shingle saying psychologist. You could have said Amanda Pickett's psychology service in 1930, and you could have been seeing patients, and nobody would have thought anything about it. But you know what, Amanda, you're a nice person, but we can't have you diagnosing psychological disorders because you just don't know how to do it, right? So you can think of 1947, 48 as sort of watershed years in clinical psychology. The APA, the American Psychological Association, sort of became more professional, and what was written was a book and a system built on that book called the Diagnostic and Statistic Manual. It was introduced in 1952, and it contains the modern diagnostic system that was invented by Emil Kraepelin, and it provides a systematic and potentially scientific approach to diagnosing psychological disorders. Now, we're now in the 5th edition, so it's been edited 4 different times, and usually what they do is they identify new psychological disorders that have been described based upon their symptomology. And what they might do is find that maybe you don't, in the last disorder, in the DSM-4, they had a diagnosis called Asperger's syndrome and autism. So you could have autism or Asperger's. Now, between the 4th and 5th edition, they decided that there wasn't enough theoretical distinction to differentiate between these disorders, and instead decided to combine them into one category called the autistic spectral disorder. So in a sense, each one of these books sort of revises what we know about the symptomology and the classification of psychological disorders. Now, what's in this book? You can buy this book, but until you become a clinical psychologist, I will tell you, you probably shouldn't buy this book and you shouldn't read this book, because you need to know what you're doing. This book can be dangerous if you don't know, if you're not a trained clinical psychologist. I have an English professor friend, and she bought one of these books, and she's self-diagnosis, which is a big danger, because people like you and me who are not professionals will see ourselves on every page. It's called Munchausen syndrome. Some of you are probably familiar with that. If you go looking through the DSM, you will find yourself on multiple pages. And what my friend does is she then goes to a clinical psychologist, amps up her own syndrome, her symptoms from the disorders she thinks she has, and she manages to fool clinical psychologists, and they keep giving her different antidepressants, and it's just not a good thing. So be careful with this book. And it's only for professionals. Now, what's in the DSM book? In the first part of that book is a disclaimer to not do exactly what I'm telling you not to do right now. And then it's going to provide professional information that clinical psychologist students should know as they are beginning to use this manual. How to find the symptoms, how to differential diagnosis, what kinds of things they should be focusing on. It's sort of a how to use this manual part. And then the majority of the book is going to be nothing but chapters filled with diagnostic criteria of psychological disorders. It's going to be listed in chapters, and each of these chapters is going to contain groups of symptoms that are in disorders that are similar to one another. So in one chapter there will be mood disorders, when they have depression and bipolar and all of the disorders that are caused by disruptions in mood. Then there's going to be psychotic disorders, which are all those delusional disorders where people aren't thinking right? Then there will be disorders related to body image, and that'll include people who have anorexia, bulimia, and some of these other body image disorders. Then there will be a chapter on childhood disorders. And then there's a chapter on personality disorders. And what each one of these chapters is going to do, it's going to go through and list each one of these disorders, and it's going to list the symptoms, just like Emil Kraepelin suggested. It's going to list the behavioral symptoms, and it's going to tell you how you should be looking at those symptoms if you're the clinical psychologist. So, for example, in the DSM, under the major depression disorder, major depressive disorder is a psychological disorder, you will notice that there are 9 symptoms in the listed in that particular heading. And what it tells you is that if you have 5 of those 9 symptoms for longer than 2 weeks, you have had a major depressive episode. And so that's what you're going to see. And then for anxiety disorder, there's going to be a bunch more symptoms. And if you have a certain subset of those symptoms, then you might have an anxiety disorder. So in a sense, each one of these chapters is going to have just lists of symptoms. And then at the end of the book, it's going to have a guide for future research. Just like I told you, between the switching from the 4th edition to the 5th edition, they decided that there really wasn't enough distinction to differentiate between Asperger's syndrome and autism. So autism is a developmental disorder in which children show very restricted social functioning, and they also have intellectual functioning. Typically, you're going to measure it. They're going to score retarded or psychologically disordered on an IQ test. So you're going to have both of those characteristics. But you know what? Some people only have the restricted social functioning, and they may actually be very high functioning intellectually. Those people used to be called Asperger's syndrome. Now what they suggest is that you should just think of it all as one big category ranging that includes some degree of social malfunction and some degree of intellectual malfunctioning. So what they do every time before they make these changes, they publish the research, and they sort of, in the back of the book, they talk about what they're thinking so that the scientific community can comment on it. I'll use this point to suggest to you that until the DSM-3 in 1973, homosexuality was considered a psychological disorder. Imagine that. How crazy and weird is that? And what had to happen, what happened between 2 and 3 was this research and comment that was done to suggest removing this particular diagnosis from the DSM. And you're going to see this in the back of the DSM, where they talk about the topics that are interesting scientifically at the moment. Everybody following me? I hope everybody's following me. If you could, just chime in real quick and let me know you're going. Looks like we've got almost 10 people following. Okay, what I wanted to show you real quick was the chapter by chapter. This is sort of the middle part of the book and what you'll see in the DSM. And you'll notice that we have these categories right here, and then there are examples inside each of these categories. So you're going to see... Thanks, KB. And so you're going to see all of these different categories of syndromes. And what we think is that we should group specific disorders based on their similar symptomology. Okay? So what we're going to be talking about tomorrow is we're going to be talking about bipolar and depressive disorders. Up here, we're going to be talking about, let me see, where's schizophrenia? Okay, so we're going to be talking about categories 2, 3, and 4 tomorrow, as well as the category all the way down at the bottom, personality disorders. I don't have time to cover all of these categories, but what I want to do is to give you an appreciation for how diagnosis is done, and then work through a couple of disorders just so you can see some of the issues that psychologists have to face when they're trying to diagnose and describe psychological disorders. All right, let's move on. Now, here's the crazy thing. How do you know if a behavior is abnormal, if somebody has a psychological problem? You might think that you talk to a person and figure their symptoms out and come to a diagnosis that they have a problem after you look at their symptoms. But actually, it works the opposite way. You go in and talk to the psychologist, and they find out if you have a problem first, and then they try to diagnose what problem it is. So you come in and you describe to me that you're having some trouble. Before I start worrying about your symptoms, I want to find out whether or not your behavior, your feelings meet one of 4 criteria. Okay? So I don't look at your symptoms first. I first listen to you. And I want to know, is what you're telling me, is it so off the wall and weird that it's just culturally unacceptable? Okay? If I hear something and you say something about your behavior that's just culturally doesn't fit in our world, then you may have a psychological disorder. All right? The second thing is, if you tell me that something's happening to you and it prevents you from going to work, it's ruining your relationship with your spouse or your children, it makes it so that you can't have friends, and it's really screwing up your ability to function, it's a psychological disorder. Or if it does it cause other people to feel uncomfortable around you? I remember I ran into a lady with Tourette's syndrome one time when I was working in a deli, and she came in, and I was very uncomfortable as this lady screamed obscenities at me. And so does the behavior that you're describing, does it cause other people distress? Is it messing up? Is it making your family sad? Is your alcoholism making your husband, your wife, your kids, is it causing them distress? And then finally, does the behavior bother you? We think that it is normal for humans to feel good. If you get up every day and you feel bad or you are suffering, we say that you probably have a psychological disorder. So you come into my office, I'm a clinical psychologist. I say, what can I do for you? And you start telling me about your life. I'm looking for you to describe your functioning as causing one of these 4 effects. If so, then I might just start to look for the symptoms that you are having. Now, which one of these? Now, the weird thing is, any one of these symptoms, if you think about it, is not a good reason to give someone necessarily a psychological disorder. For example, before 1973, it was not seen as culturally appropriate to be homosexual, right? And so if you violated that cultural norm, even if you were okay with it, even if your family was okay with it, you might be given a diagnosis of having a psychological disorder. So that's not really a great reason to give someone a diagnosis. If it bothers other people, yeah, that's a reason too. But really the most important reason that we give people diagnosis of psychological disorders is when something that's happening to them really, really bothers them. All right? So we don't look for symptoms first. Instead, I look for you to come in and tell me about your life and find out that it's making problems in one of these 4 areas. And the one that's most important is it disrupting your own sense of happiness? Now, if you come in and you tell me about your life and I notice that you're meeting a couple of these different categories, especially the distress one, then I start listening to your symptoms to see if I can figure out what collection of symptoms you have so that I can then tell you what psychological disorder you may have and I can begin treatment for that psychological disorder. Does that make sense? Violetta, thank you for coming in. Better late than never. I appreciate your effort. We're talking about psychological disorders and how to diagnose them. And so remember, I'm not looking for a diagnosis yet. First, I'm looking to see if you are feeling abnormal, if something about your situation is causing problems. If so, then we move on to the second step, which is diagnosing your psychological disorder. Super, super, super difficult. And back in the day, they used to do it willy-nilly with absolutely no science, no procedure, no systematic nature. You would just go in and talk to a clinical psychologist, or talk before clinical psychologist. You would go to talk into some case study worker, and they might give you a guesstimate of what you had. Now, psychology definitely in the mid-20th century decided to be more systematic in order to give better diagnosis and to help people more efficiently and effectively. And so what you're going to notice is that psychology has borrowed from medicine this procedure and a set of terms that we use to guide the diagnosis process. Now, we do this so that we can come to the correct diagnosis. Just like a medical doctor wants to get the correct diagnosis for you, we want to get the correct diagnosis for you. Unfortunately, we don't have x-rays, we don't have blood tests, we don't have MRIs, we don't have a lot of the things that a medical doctor has to really make sure they get the accurate diagnosis, right? There is no depressed bone that can be broken, you know what I mean? There's no blood test for anxiety. But absent that, we're going to try to use the model of the medical school to come to the most accurate diagnosis. And we're going to use some terms that you should be familiar with. So when you go to a medical doctor and tell them that your foot is hurting, you are giving them the presenting problem. When you go to a clinical psychologist and you tell them that you've been crying for 3 weeks, that's the presenting problem. It's the answer to the question, why are you here today? Just like in the medical field, the psychological field has what we call a presenting problem. And you know what? That's the first thing the psychologist is going to write down when you come in. Well, doc, I've been crying for the last 3 weeks. Patient reports crying for the last 3 weeks. You know what I mean? That's how we're going to start this. Now, if you'll look here, your book has this chart, and I'm going to add some stuff into it, like presenting problem. But then what we're going to do is we're going to go through an assessment of you. That's the next thing we need to do. Just like a doctor's going to give you blood tests or x-rays or whatnot, psychologists are going to measure you using the tools that they have. Now, what are those tools? You'll notice across the top of this screen in the blue boxes, we have Thank you, page 552. Kyle for the assist. We have interviews. Okay, so what we'll do is we'll interview your parents. If you're a child, we might interview your parents, your school teacher, people who know you to get their opinion, right? Now, I'm also going to let you tell me what's going on. So I'm going to let you tell me, and you may come in and tell me this. Now, I'm going to talk to interviews to your friends, and I'm going to find out if they agree with your estimate. So are you describing something completely different from other people that know you, right? I'm then going to give you psychological tests. We've talked about IQ tests. You're going to get those in a psychologist's office. We talked about personality tests. You're going to get those in a psychologist's office. We're going to talk about personality disorder tests. You're going to get those in a psychologist's office. Self-esteem, achievement orientation, all of these things are going to be measured. And in fact, I've seen the diagnostic paperwork for some people who've gone in to see clinical psychologists, and sometimes they'll make you take 20 and 30 different tests that are all designed to provide an accurate assessment of you, along with your self-report and along with the report of people who know you. And then, you know what, while I listen to you, I'm going to make my own observations. What do I notice about Amanda Pickett or KB or Needy? What am I noticing while I'm talking to them? And I'm going to use all of that to come to an assessment about what your behavioral symptoms are. I'm then going to make what's known as a differential diagnosis. What do you have? Now, we call it a differential diagnosis because just like in the medical profession, you go in, your leg hurts. Is it a broken bone? Is it a sprained ankle? Is it a torn ligament? I don't know. We have to do a differential diagnosis to figure out which one of these problems you have. When you go into a clinical psychologist, are you manic? Are you bipolar? Are you depressed? Do you have dysthymia? Do you have cyclothymia? Do you have seasonal affective disorder? What is the nature of your mood problem? I'm going to have to engage in a differential diagnosis. Now, your book doesn't talk about it, but just like the medical profession, in fact, your book's going to hint at it in the text when it's describing these disorders. We're interested in incidence rates. How often do they occur? Did you know people say that depression, major depression, is like the common cold of psychological disorders? They say that almost 10% of the population will suffer from a major depressive episode at some point in their life, right? And then etiology. We're going to try to figure out what causes these psychological disorders. Now, some of these psychological disorders have a genetic component. Some psychological disorders do not have a genetic component. Some psychological disorders occur because of biological problems. Some psychological problems occur because of abuse and stress, or drugs that you may take. So we want to know what causes the problem, because before you can fix a problem, you kind of got to know what's causing that problem. Then the part of the process is treatment, and we're going to focus on treatment in more detail in chapter 15. But I will tell you that you're going to get two kinds of treatments when you go to the clinical psychologist: a biological therapy, drugs of some sort, or electroshock therapy or whatnot. And then they're going to give you some psychotherapy, some talk therapy, which deals with the psychological issues. Now, and then we also know, just like medical doctors are, we know which disorders go away, which other orders don't, and what is the pattern of their manifestation. That's the prognosis. What's likely to happen left treated and untreated. Tomorrow we're going to talk about schizophrenia, and I'm going to tell you that there are three broad styles of having schizophrenia. Some people have one schizophrenic break, goes away, and they never have a problem again. Other people have schizophrenic breaks in normal periods, schizophrenic breaks in normal periods, and they kind of go in and out of schizophrenic episodes. And then you have a third group, which are the chronic schizophrenics. And once they have a schizophrenic break, they never come back. And so we know what is likely to happen to these people, and we know what happens if you give them medicine. That's sort of a prognosis. And so the idea here is that we are trying to be systematic in how we evaluate your psychological problems. But keep in mind, there is no blood test for schizophrenia. There is no depression bone. In the end, psychologists are simply describing behavior and not looking at biological components. Now, you may not think that's crazy, but imagine if you went into a medical doctor because you had fallen and your arm was hanging off, and your doctor said, well, does your arm hurt? And you're like, yep. And you're like, well, did you fall and hit it? And you say, yep. And then the doctor says, can you move it like this? And you say, nope. And then the doctor says, well, it must be broken. Let's go ahead and put a cast on it. You would probably be freaked out. You'd want to see an x-ray or something. We don't have that in psychology, so we have to rely on what you describe. And so we have to be super careful and super systematic in how we gather this behavioral information. Does that make sense? And by the way, thank you, KB. Now, and one last thing that I do want you to know is we also talk about this term called comorbidity. So, just like different physiological syndromes can manifest themselves together, even though they may not be a part of one another. So people maybe who are overweight may have heart disease and may also have diabetes. So those two disorders are comorbid. They kind of co-occur together. They're caused maybe by the same thing, but they're completely different syndromes. Just like we have the idea of comorbidity in the medical field, we have the idea of comorbidity in the psychological field. And so we're going to talk about that too, which disorders tend to co-occur with other disorders. And I will tell you, we talked about phobias in Chapter 7. Really, phobias aren't covered too much in the DSM except for social phobia, agoraphobia, and claustrophobia. Most of your phobias, like your clown phobia, is not going to be covered in the DSM because they typically don't have any behavioral impact. You may be terrified of jelly beans, but that really doesn't affect your life, right? So psychologists don't treat it because it doesn't have any impact on you. But some disorders do have phobias that go along with them. So, for example, we're going to talk about panic disorder, which is when people have these sympathetic nervous responses. They freak out and they lose control and they have this really horrible sort of terrifying experience. People who develop panic disorder tend to develop an agoraphobia, a fear of leaving the house because they don't want to lose control outside of the house. And so what we would say is that for 50% of the people who have panic disorder, they're going to have the comorbid condition of agoraphobia. Do you see what that means? Two separate, distinct disorders, but they tend to co-occur because the situations that cause one may cause the other. So we talk about that. Now, I know we didn't talk about any psychological disorders today, but basically what I wanted you to understand was the process, the mindset that your psychologist is thinking about when they go through and try to figure out what psychological disorder you have. Remember, we didn't used to use symptoms, but now we use more of a medical model that involves collections of symptoms and this medical terminology that allows us to figure out where disorders come from, what's likely to happen to them, and how some disorders are different from other disorders. And the idea is just to be as scientific and as accurate as possible. Because you know what? It's really hard to figure out why people have psychological disorders or what disorders they actually have. And we have to use this DSM because it is super systematic and it helps make sure we think in a logical, systematic process. And then, and like I said, we have to diagnose the patient from looking at many angles because we don't have biological tests that can tell us whether or not a person has a disorder or not. Do you have any questions? That's probably all I wanted to say today. I just wanted to introduce the idea of psychological disorders. Any questions? I was going to go outside and play today, but it's too hot to breathe. So I'll have to figure out some way to keep myself active inside today. I hope you folks are doing well. The last homework assignment will be available probably tomorrow morning, first thing, and then you can get started on homework number 8. Yeah, it'll be available tomorrow morning. I'm dragging, but sorry. I'm doing the best I can. But thanks for coming today. I hope you folks have a great day. And I will see you tomorrow morning at 11 o'clock. Take care.
Your call cannot be completed as dialed. Please consult your directory and call again, or ask your operator for assistance. This is a recording.